A very warm welcome to Plenary 2 of HSR 2020. My name is Pascal Alate. I'm the Director of the United Nations University International Institute for Global Health. In the virtual format, the plenary is in two main blocks. Please enter questions in the question and answer tab and engage through the discussion forum. In the interest of time, we will get started straight away. The first session is pre-recorded with our eminent panelists. We will have Dr. Hamza, Dr. Kolika Vikramage, Professor Chris Ebai, and Professor Valeska Kaifa. The second block is a live conversation with an opportunity to address your questions. We will get started now.
Welcome to the second plenary of the 6th Global Symposium on Systems Research. This 6th symposium, anchored by Dubai for the Eastern Mediterranean region, gives us the opportunity to reimagine health systems for better health and social justice. The theme for the symposium couldn't have been better timed, nor the circumstances better orchestrated to sharpen the opportunities for learning. The COVID-19 pandemic has put health systems under a microscope for the quintessential instrumental case study, an opportunity for realist methodologies to be deployed to review our understanding of what makes an optimal health system, to redraw generalizations, and to reposition the role and importance and impact of context on our health. So this second plenary, engaging social, economic, and environmental forces, responding to population mobility, conflict, and climate change, is an attempt to connect the dots between systems and health systems research and the critical global contexts that are increasingly stressors to test the robustness and resilience of our health systems. We want to explore the role of health systems in engaging proactively with these contemporary challenges that pose risks to peace, security, and sustainability. I refer specifically to conflict, to climate change, to the mass movements of population, and to rapid urbanization and the creation of megacities. These have resulted in wicked problems, interrelated in both cause and effect, and intersect with the social determinants of health and ones that need to be brought into health systems discussions. Acknowledging that global crises require both global and local solutions, the plenary will explore the critical intersections of each of these areas with health and health systems, the existing mechanisms, the norms and standards that could be used to address these challenges, and engage with you in identifying entry points for action through research and rethinking health systems into the future. The result is a series of conversations with amazingly engaged experts, able to communicate both their areas of expertise, as well as to integrate them into a broader health systems perspective. In whatever manner we conceptualize health systems, there are almost always some underlying assumptions. That there is a society and population which we understand reasonably well and for which it is possible to plan, that there are political structures, norms, and standards and systems that support existing institutions, that there are resources, financial and human resources, that support planning, even if these resources are constrained, and that health systems exist within a somewhat predictable ecosystem that always allows for some planning. These are described as the hardware and software of health systems. Over 4 years, Hamza ran the only hospital, effectively the only service, that passed for a health system in East Aleppo. This is his story to tell, so I will bow out now. But we will start by playing the trailer for the documentary to transport you to the extreme end of a health system stripped almost entirely of the basic hardware and software elements to open up this plenary. I would also strongly encourage you to watch the full documentary. I assure you, you will not be disappointed.
بحلب مدينتي. لسه عم صور. هذا الشيء اللي عم بيخلي معنى لوجودي. ما حدا منا كان عنده أي فكرة
دكتور حمزة
كيف رح تتغير حياتنا للأبد.
حمزة أنا حامل. سما سما
سما، عملت هالفيلم مشانك. بدي إياك تفهمي شو اللي كنا عم نقاتل مشانه.
بحبك كثير أكثر من
أصو في ضرب كثير اليوم. سما، أنا بعرف إنك عم تفهمي شو عم بصير. بقدر أشوف هالشي بعيونك. ما عم تبكي مثل أي طفل عادي. هذا الشيء اللي عم يحرق لي قلبي. سما، رح تسامحيني؟
So may I ask you, as just to kick off the conversation, can you please provide a brief overview of the experience of being responsible for the only functioning hospital over a certain period of time, but also given the duration of the problems in East Aleppo and the problems with the health system, and given that this was all within a complex setting, can you please give us a brief overview of your experience, please?
So thank you all for the wonderful work you're doing, and thank you for having me to talk about the health system in conflict. So my name is Hamza. My real name is Zahid, but like my family called me Hamza, and through all the time I worked in East Aleppo, I was called Hamza. So that's why I'm sticking with that name. I'm like just a medical doctor, graduated in 2011, and then moved to East Aleppo.
Responsive, or did you have a plan? Did how did it all come about?
So in at the beginning, at 2012, it was just like responsive. The idea of the hospital that I started was we were just a group of doctors, and we were just saying that there are like all the focus was on trauma and trauma medicine and the emergency responses, and there is like no more care about the population that is there. So they all like the gynecology, pediatric, and other aspects of medicine. It's kind of like similar to what happened in the first of COVID, when everyone was focusing on COVID and they forgot about the chronic disease and cancer patients and all of that. So it was kind of the same exactly in 2012 when we decided to start the hospital to be like just kind of a chronic like disease hospital with like reproductive health, maternity, and pediatric. So it's kind of like that was responsive to the situation, like the increase of population in East Aleppo and like the more focus of trauma. In a couple of years, more structure like start to happen, the more coordination between the few hospitals that were functioning, more gathering of the doctors that were working there, to more like structure and kind of like build the health system in the area. One of the think, issues that we had, that there was no concept, no understanding of a concept of the health system component, and like the kind of like the public health thinking in the area, as we all were like just doctors, and we usually just like focus on patients without like the overview on the like kind of like the health system or the population health. So like we had to understand that concept and then start to plan based on that, and like kind of divided like the health services per facility. The also kind of say like, because we were kind of also responsive to the NGOs, so based on like what the fund they had and what the fund was allocated for, that was also one of the, like, let's say the health system was built by NGOs there, and it was only by like the NGOs fund they had. And because of like kind of the limitation of the fund purposes, so we had only to respond to that. And that was also one of the issues we suffered from. Like at one time, all, for example, the need assessment that were done by the main donors, like say ECHO, USAID, or like the German government, it was like, oh, there was like, do you need to pay more for maternity hospitals or like maternity facilities? And suddenly, like it was like 2 hospitals in Aleppo, 10 clinics and primary healthcare units for maternity, while there was like no much like kind of allocation for other needs. And that was also one of the issues.
So given that experience, what would you say are the absolutely critical components of a health system that need to be maintained even during conflict?
So I guess you can't just like, you know, give like preference from like to one component to another.
What were the imperatives for doing this, given exactly what you have said, that that very often there wasn't really opportunities for planning? What were the imperatives for doing?
I won't say from myself, from like the hospital board, let's say, that we will just focus on employing basically more like females than males, because they will be like more supportive for the families through like the salaries and the staff. One, then the other challenges that we had, that there was no safe spaces for those like employees' children's, that they can't just leave them at home in a conflict area and come to work. You can't just like admit the infant, for example, in an incubator, and then just accept the family to leave him or her, like to leave that infant for like few days, and they just go home, where like the hospital might be attacked, the area, the neighborhood might be attacked. So we kind of had to understand that, and like then provide all the other like necessary, like, so place for those people to sleep, for like the patients like families, even though like we weren't allowing only like one basically person to stay. Then that will reduce, like through the siege, for example, we need to produce them food for those people. So it was like more than just like a health focused whole like independent health service provider, but like to a broaden like view of the other needs for the society, in order to make this health services like applicable to happen. I think that's more to like a public health point of view, and that's why I'm starting the master in public health.
What is needed to rebuild a resilient health system in this post-conflict time?
So I guess I can think of 2 major things in addition to what was already like adapted. So the first of all, the kind of like the like the fund to kind of like to build the infrastructures. I can remember like the main thing that we were struggling of to get the fund to protect the hospitals, like basically to create the safe space where you can provide the health services. And the main thing, like main quotation or like answer that I was always hearing, that we don't have fund allocated for like building things or like infrastructures or sandbags or like preparing a basement for like health to provide health services. So it was like most of the fund was allocated for like salaries, procurement, medication, consumables, but there was no much thinking of the kind of like the construction work that is needed. That would like protect, like providing this safe space will allow the health worker to work kind of with like a trust that they are at least like protected, even that there's no like not 100% protection because of the shelling and the warcrafts. The other thing is the referral system. So basically, like the organized, like the coordination between donors themselves, which will also then reflect on the INGOs and the NGOs, is the most important thing. And also listening and hearing from the healthcare like provider, the people on the ground that knows the society better, knows what the real need is very, very important. I can remember like there was kind of like, I can say like now, like we're in 2020, I can remember 2014 was the maternity year for all donors in Aleppo. Yeah. 2015 was the GBV year for everyone. It was all important, but like then there was forgetting about like diabetes patients. We were struggling to get medication for most of the chronic diseases, and a lot of donors were thinking about those like, oh, there's like limited like patients that suffer from that disease, and it was very costly to provide the medication. There was always like very focused on the allocation of funds to kind of provide the service for the maximum amount of patients. But there was kind of like, I think like adding, it's not like, it's important, yes, but then there was also some like thinking of like the dialysis, for example.
With the negotiation with the funders and the kind of the external support that you had, was that also something that was left to you?
Yeah, and it actually like depends on the funder or the INGO we were like receiving the fund from. There was, I think it just, I don't know if it's internal policy or just like based on the person we were dealing with. Mm-hmm. Sometimes they were very like kind of like strict that this is the fund that we have, this is the allocation, that's it. Sometimes they were like we were more involved in the need assessment period to build the project that we need. But in most cases, it was just like, this is the fund and this is the allocation for it. And it's also like we had to work around it, you know. Sometimes one of the stories I will tell, like, for example, I really need to, in Al-Quds hospital, I really need to have another ward for hospital, like for admitting people. Because like we were only like 24 bed, and we were easily kind of like with a small amount of money to make it to double that from like 24 to 48, which was like very essential in Aleppo. And I couldn't find any basically like fund for construction. But when we then like shift the project and we make the aspect of it's gonna be kind of like a GBV project, that we're gonna separate men from females, and the fund was there in 5 minutes. So then like it at the end it's the same purpose, but we had one donor that were really like cooperative with us, and then we just like basically changed the aspect of the project we were doing. And then we got the same like like the same result, which is like adding 24 beds to the hospital capacity. So yeah, it just depends on the donor how to negotiate with him and how cooperative they are.
You now have more expertise in managing this than anyone that certainly that I can think of, and probably anyone who's managing the funding for this sort of work. How do you think you would fix it?
I think basically is more engaging the local people, the real healthcare providers in the planning phase.
Okay.
And trust them that they know actually what the society need, and not only focusing on one channel of communication with like one person or one hospital, but also like allowing more hospitals to cooperate with them, which will like then the NGOs and the donors.
Dr. Hamza, congratulations on the many well-deserved awards. I can see the BAFTA behind you on your wonderful work. And thank you so much again for your contribution to Health Systems Global and to the 6th Global Symposium for Health Systems Research. Thank you. We're really grateful.
Thank you very much for having me, and looking forward.
Our final formal presentation is by Dr. Kolita Vikramange. For many of you, Cole needs no introduction. He is with the Health Division of the International Organization for Migration, based in the Philippines, but is currently a COVID refugee working out of Sri Lanka. Cole's work covers migration from multiple perspectives as it relates to all the stresses highlighted in the previous presentations. Movements of populations following conflict, disease outbreaks, internal and international migration, and the impacts within host countries for migrant workers and their families. His expertise is in research and evidence generation across IOM's 3 health programmatic areas. He looks at medical examinations for migrants and refugees, technical cooperation on migrant health with member states, and health action in humanitarian and post-crisis contexts. I can't think of anyone with the breadth of experience able to address the complexities of migration in health systems research. Cole, you have the mic.
Thank you very much, Pascal. So I guess I'll start by contextualizing migration and health before I dive into health systems, responses, or research at the nexus of migration, health, and health systems. I think there's no doubt that migration is one of the most important geopolitical phenomena of our time. It's indeed embedded in current political discourses, debates, but I think the understanding between migration health for policymakers, for practitioners, civil societies, and researchers has been quite challenged in this overall, I suppose, toxicity within the migration discourse. So I've got to start by setting some parameters around what do we talk when we say migrants. I think one of the great oversights is to generalize migrants as this homogeneous group. And I really want to be aware that when I speak of migrants in this particular presentation, I'm specifically speaking of international migrants, so those moving across borders. Now, of course, the vast volume of migration and mobility is internal. And so, but this is important to note, because I think we've often seen in even peer-reviewed publications to forums and debates, policy debates, people using the word migration, but without giving this context. I just really want to be assured that I'm talking about international mobility here, but in particular within low to middle income countries, and that also with labor migrants, the low wage and the low skilled. So the valence of my presentation is from that perspective, just to anchor this. So in terms of some numbers, the UN estimates, and this is UNDESA, there's around 272 million international migrants. And this includes refugees, asylum seekers, but the vast majority, the highest number is labor, people moving for purpose of work and for employment. And I think that in this policy debates and discourses, this is often forgotten. The valence of discussion is often on the undocumented workers, and indeed those who overstay visas. And so the international attention and the political attention is often on the undocumented. And I think it's important as researchers, as system analysts and health policy folk, that we really are aware of the larger categories of mobility. And I think this is important, and I'll come back to this in discussing health system research agendas as well. So what we can say is the effect of migration and health is a complex one. So if I can go to the next slide. And when we talk about, as a health systems perspective, it's important to understand health systems research in the context of migration involves not only of the particular destination country, but it also engages the sending country, those systems in transit countries. So this complicates exploration and understanding of determinants of mobility and how it affects human health. But I think it's really important that there is, for example, in the case of labor migration, a cyclical dynamic in terms of human mobility. So understanding these different phases and understanding the determinants through these population movements is important. And calibrating this to, for example, understanding health systems in point of origin and destination, and when the migrant returns. So, for example, a remittance sent home by a domestic migrant worker in, say, for example, the state of Qatar, may enhance the nutritional status of her children left behind. However, that particular left behind family, the caregiving might be shifted towards grandma, and therefore the reshaping of healthcare burden on the elderly of that particular sort of labor sending community might be adversely affected. So there are differences in and complexities in understanding the effect in this case of domestic labor migration and the impact of remittance on health and well-being. So this is sort of a small example to highlight the kind of I suppose challenge and approach one should take when looking at, for example, migration for development or migration for poverty alleviation. I think health systems folk really need to understand the migration cycle and also how health systems in points of origin, destination, and when the migrant returns really affects this. I must say, despite some progress in the international arena in terms of advancing migration health, I mean, we've had multiple World Health Assembly resolutions, the development of the Global Action Plan with WHO, IOM, and partners, and we've had the Global Compact of migrants and refugees, where health is indeed enshrined. However, we have a long way to go when it comes to migrant inclusion, inclusion of migrants in a meaningful way within health systems, within health programs, within vertical control programs. So as an example of this, I draw upon this small piece of work that we did way back in 2018. This is well before the current COVID pandemic. And we looked at migrant inclusion within pandemic preparedness plans, in pandemic influence preparedness plans, in particular in Asia Pacific. So this was 21 countries in Asia Pacific region. And this was research done with colleagues in Thai Ministry of Health, in the Chatham House, and so on. And so in this short policy analysis, we found only 3 countries that had explicit mention of migrants within national pandemic preparedness and response plans, and that too has different valences and different coverage capacities. But I'm not going to get into that here. Only one look at coverage or explicit mention of the undocumented migrant workers. So I think this is an example of research at, inclusion is a core part of looking at the practice of migration and health. And I think a lot of this has not been done. So, a question that if you're a TB researcher, you can ask is, to what extent does the National TB Control Program take into account different migrant categories within exploring TB coverage, DOTS coverage, for example? What is the proportion of cross-border migrants that are accessing the DOTS treatment, for example? So that's from a vertical control perspective. But this is one of the challenges in advancing migration health evidence for policy and practice, is that we are not seeing this data. I want to go into some of the gaps, actually. So this particular bit of work that we did was really exploring who does what where in terms of migration health research and output. And it's clear that low-income countries produce the lowest yield of research in migration health. And if we look at by categories, and remember I mentioned the vast majority of international migrants are labor, moving as labor migrants. In fact, 61% of the 272 million. Yet, when we look at the research productivity and the evidence generation, it's only 6.2% of the total volume. So, how are we informing decision making? And this also goes to a point around scholarship, collaboration from the global south in driving the evidence base in migration health research and health systems research. So I think we are a long way in sort of I say it's sort of we're in a nascent phase as a field of public health in migration health to drive evidence, and I think this is played out in those research studies. So from a health systems perspective, and this is some work that we did with Helena, Martin McKee and colleagues. This was part of our BMJ Migration Health series, and I encourage you to look at this. And it really sets out some of the key factors from a health systems perspective that affect migrants, both enablers and mitigating factors or obstacles. Again, I don't have the time to take a deep dive into this, but on all aspects of the health systems framework, from governance to healthcare financing to the healthcare workforce, there are multiple facets of, for example, if you look at healthcare financing, it's interesting that how portable is the health insurance scheme for, say, domestic migrant workers going from, say, Sri Lanka to the Gulf states. What level of coverage does that migrant worker have to primary healthcare access, sexual and reproductive health? Unfortunately, the data are very scant. And I think as migration health systems scholars, we really need to take into account not only the health sphere, but also government to government agreements. So if one is going to do a meaningful in-depth analysis of a policy analysis, one really needs to look at those labor agreements, industrial relations laws. To what extent do they cover the non-citizen, for example? And I think this is the type of approach we need to have when we're approaching a migration health systems perspective. I want to end off by pivoting to the COVID-19 pandemic. And I mean, I highlighted, for example, some of the key ways in which health systems policymakers, researchers, practitioners could look at this space of migration health. But it's also important to identify, well, what are some of the good practices? We all know that in the context of COVID-19, migrants and mobile populations have been quite marginalized. They've been at the forefront of shaming or blaming, for example, as vectors or as moderators of this pandemic. Here are examples I wanted to share on some of the more migrant inclusive approaches that we have seen so far to date of migrant inclusion within COVID-19 preparedness and response plans. So for example, Portugal had temporarily regularized the irregular migrants to ensure access to COVID-19 services. The government of Peru approved a temporary health card for mainly Venezuelan migrants coming through Tumbes into Lima. And Singapore had set up some medical facilities in triage for migrant workers in dormitories. And again, at the initial onset, however, those migrant workers were not included within these response plans. And with the surge of the second wave, then these measures were taken. And I think, and again, so there are some good examples where health systems, health authorities have been proactive in ensuring coverage and inclusion of different migrant groups, but there's still a long way in which we need to understand and identify how migration and COVID-19 is impacting. I must say this has been a sort of a very short presentation, but one of the things that I wanted to end off in is how the existing health systems capture data on migrants. And I think this is one of the real challenges where we look at how routine health information systems have failed to really include or be inclusive of, say, a migration module. But of course, with the caveat that there needs to be an ethical and data protection framework surrounding these type of modules as well. So that's important to say. And something that we're working on as a sort of a way forward is that we're trying to pilot these type of migration health country profile tools. And it's something that we've been doing within the Middle East, North Africa region, and also the African region. And these are some of the things that we've been working on to ensure better data. And for those of you who are health system researchers, I leave you with an example from a low to middle income country, in the case of Sri Lanka, on how health system research has really informed policy and practice there. So thank you very much. I know this was a very short presentation, but I hope it gives you some insights. Over.
Thank you very much, Paul. I look forward to the discussion with you shortly. Thank you.
Thank you, Pascal.
Professor Christy Ebi is Professor of Global Health and Environmental and Occupational Health Sciences in the Department of Global Health at the University of Washington. Chris's work has focused on the health risks of climate variability, including extreme events, thermal stress, food safety and security, and vector-borne diseases. How do we ensure that health systems are able to respond to these threats? Professor Ebi, you have the mic.
Thank you very much, and I really appreciate the opportunity to talk with everyone today. Good morning, good afternoon, good evening. I hope you're enjoying the symposium very much. As you can see, I'm going to talk a little bit about the health risks of a changing climate. Our climate is changing. Not only are we seeing increases in global mean surface temperature, we're also seeing increases in the variability of our weather. We're seeing more heat waves, more droughts, more floods, and more wildfires. We're seeing these at multiple locations around the world at the same time. And we're also seeing more of these events back to back, of seeing 2 major storms hit in Asia, for example, mostly back to back, of looking at the number of typhoons in the Atlantic, hurricanes, and how many are hitting landfall this year. So lots of changes are going on in our environment. And the question is, what does this mean for our health? I talked a little bit in the previous slide about some of the changes that we're seeing. And as the slide evolves, you can see around these changes are exposures that are important for our health. Severe weather, air pollution, changes in vector ecology. Around that circle, you see a not complete list of the kinds of health impacts that we're looking at. I have the privilege of spending time in low and middle income countries, working with ministries of health. And these are most of the issues a Ministry of Health needs to deal with. We have estimates for the significance of these right now. These are all current problems. And the projections suggest that with any additional unit of climate change, for most of these, we'll see larger burdens of disease. Diseases will change their geographic range, their seasonality, their intensity of transmission. So without taking additional action, we're looking at a future that will see a very much larger burden of climate-sensitive health outcomes. And it's not just health outcomes, it's also our health facilities. These include our healthcare facilities, but also our public health facilities, our laboratories. I will not go through the slide, but it emphasizes the same point that our facilities themselves are also vulnerable. When you look in many countries, we have healthcare facilities in coastal zones. We have hospitals along rivers that flood. We're seeing impacts on the facilities in addition to greater numbers of people coming in for care because of climate-sensitive health outcomes. When you think about all of those health outcomes, when you sum them up, over 85% of those health outcomes are in children. So when you think about climate change, I really hope you think about children. Undernutrition, diarrheal disease, malaria are all diseases of children, and they're the ones who are suffering the most. There are many, many activities that can be undertaken to reduce our future risks. The World Health Organization has an operational framework for building climate resilient health systems. The figure on the left shows you some of the building blocks of health systems and shows you some of the many activities that can be undertaken. As I mentioned before, all of the health risks of a changing climate are current problems. We currently have programs to manage diarrheal disease, malaria, etc. We're going to have to be smarter about how we manage these in the future as we see shifts in the disease patterns. And the good news in all of this is that there is an enormous amount of environmental information. We have climate information, weather information, and we have a pretty good sense of how things could evolve in terms of our environment over the next couple of decades. We have the opportunity to use that information to, for example, develop early warning systems so that projections don't have to come about, that we will still see changes in climate, but we won't see changes in our health. And I talked specifically about the health outcomes that we think about from the perspective of ministries. And I wanted to include this in my talk. It's from the Intergovernmental Panel on Climate Change. And when you look at each one of these figures, the white area is where we don't know there's been a change in that particular system. As the colors go to yellow, to red, and to purple, it means that the risks are higher and higher. The Earth has already warmed 1 degree, that's the gray bar across the middle. And so if you look at warm water corals, there's already been a significant change in warm water corals. And this particular special report concluded that an additional ½ degree of warming from today means we'd lose about 75 to 90% of our warm water corals. At 2 degrees, they'd all be gone. But it didn't take the next step because the literature is not there. Hundreds of millions of people get a significant proportion of their food, their protein, from the fish that live in the warm water corals. So when you look across all of these, you can think about how these also affect our health. And this leads to the conclusion of we're facing a very large challenge, and all of us have various ways that we can engage to make sure we incorporate climate change into the research that we undertake, the interventions that we implement. And I wanted to end with thinking about mitigation, reducing greenhouse gas emissions. And we know from a robust literature that almost all of the mitigation policies have health benefits. That if we could implement mitigation today, we would reduce avoidable hospitalizations, we would reduce avoidable deaths from air pollution, from our diets, from road traffic accidents. And you can see the study from New Zealand showing that just a small shift can make a really big difference in health and in our healthcare costs. With that, thank you very much, and I look forward to the discussions.
Another important global priority that cannot remain peripheral to our concerns or planning in health systems research. Chris, we look forward to exploring these issues further in the conversation with the rest of the panel. Thank you so much for your time and for sharing these insights. Thank you.
Thank you.
It's my absolute pleasure to introduce Professor Waleska Kaifa, who is a professor of epidemiology and public health at the Federal University of Minas Gerais in the School of Medicine with the Belo Horizonte Observatory for Urban Health in Brazil. Professor Kaifa has forged a career that spotlights the impact of urban spaces in health and health inequalities. She's passionate about ensuring broader engagement of communities in the planning and policy process of urban development, ensuring access to data for decision-making. Waleska, please take us away and tell us why within the area of health systems, we need to pay particular attention to urban health. Over to you.
Thank you so much, Pascal. I want to thank the organizers for this special moment. I'd like to say good morning, good afternoon, and good evening for ladies and gentlemen that are attending the 60th Global Symposium for Health System Research. And I must tell you that it has been a very challenging work in terms to do this plenary, not because of the plenary itself, but because it's rather complex, the issue. So I will be presenting briefly what we have done here as urban health. That's my expertise at the Observatory for Urban Health. I'll go over some intersection of health and urban system at local level, try to bring the urban health conceptual model, and especially looking at the necessity for data, for metrics, for evaluation. And I will try to reflect with you the entry points for action to research in health system by the end. So when we think about urban health, we need to think about local health in terms of the integration of several systems as the urban composing the urban context. So we have several systems that working in driving force through a good or a bad health of its citizen. And also we have to think about the health system in this interconnecting all those urban systems, and of course to understanding the physical and social environment that modulate the health of urban residents. So thinking about urban health, we must think about local level in terms of looking at urban. So the pillar of urban health conceptual model are that three, and essentially they are based in health inequalities, meaning that health is worse in dense population, living disadvantaged area. The spatial inequalities means that health, we have a very differential space in terms of access to natural environment, lack of sanitary conditions, electricity, housing, and even health system. And also health is beyond individual determinants, being function of social conditions, racial, gender, income, and a lack of segregation. I think that what most important here in this conceptual model is that we need to get basic information, intra-urban information, in order to be able to combine this information in several levels and to be able to evaluate health policies or evaluate the necessity of health policies, or even to determine that some health policies, they can be harm for the health of the citizen. So bring some example as an intra-urban vision in terms of local partnership. I want to share with you the intra-urban differentials for SARS-CoV hospitalization here in my city, in Belo Horizonte City. It's a 2.5 million city with, unfortunately, still 50% of the population still live in very, very informal settlements, as you can see in this picture. So with a very strong partnership with the the city health department, we've been exchanging information, data of hospitalization, and we are geocoding, organizing this information, geocode this information in the territories of the city. And in informing the community through an informative called InfoCovid Observatory. So as you can see in this picture, we geocoded either the hospitalization or the death in the territories of the city. We can see that underlying this very concentration spots, red spots, meaning the higher density of either hospitalization or death. We can see this little line here in pink, and they are the vulnerable area in the city. So the bottom line is the distribution of the COVID-19 hospitalization are not equal in the territory or within the city. And as we can see here, we also see that hospitalizations are it's higher, the likelihood to be higher among those living in formal city as compared to formal city. So we see a very unequal distribution within the city. So the entry points for action through research, health, and urban system is that COVID, understanding COVID is a big event, leading a crisis like a civil war, and it interacts of health and urban system from global to local. So we need local actions, even though we can have in different levels of decision, global, regional, or so on. So we need to coordinate actions from global to local. We need to understand the dynamics, the interaction between the dynamics or the system dynamics in terms of health system and urban system. And so we need to go within and beyond the health system. And for that, we have to call for intersectorial action in a local level. Crucial for us to understand everything before is we need data, because no data, no action. We need critical intra-urban data for a rational action based even in incomplete or inaccurate data, despite the fact that COVID is the first pandemic of the digital area. Also, we have to think about the syndemic approach in urban settings in terms of the interaction between infections and the NCDs. Now it has been described this biological and social interaction between conditions and states, clusters in vulnerable intra-urban territory. So we need to face the COVID in a more nuanced approach. Also, this epidemic, as any big event, are unhidden the structural racism, gender bias, and the social inequalities as the big wound that's getting worse and worse. So we need to address the right of the city, the safe living conditions, the social justice, security, and protection. Also, we need peace to work, peace to deal with our problems. And last but not the least, we have the economic and political crisis that now we are facing here, especially in Brazil, which together with corruption, lack of transparency, lack of accountability, and essentially lack of governance, we need to meet an urgent fiscal accountability, avoiding toxic decisions, and sometimes very bad for the health, taking in consideration that they are based on they are not based in any science at all. So I'd like to thank you, and I hope we can enjoy this conversation.
Thank you very much, Valeska. I think you'll all agree with me that, again, Valeska has really highlighted and thrown a spotlight on the complexities of the externalities that we really need to bring to bear in thinking about health systems and making sure that we build them to be resilient across all of these different considerations that we have. Particularly thinking now about the fact that megacities are going to be very much a problem of the future. And so in the interest of time, I will wrap up this section. But Valeska, before we move into the plenary section with the questions, I'd like you to think ahead of that, where you think our blind spots would be in thinking about the nature of cities and how we make sure that we are intersecting properly with health systems in the planning. So we'll end this section. Thank you very much. I have to say, wow. Can you join me in a very warm HSR 2020 appreciation to all the panelists? That was amazing. You've seen and heard 4 presentations, each of which address a major issue in its own right. And indeed, we have special sessions as part of the symposium that takes each of these areas of focus. So what we want to do here is to try to break down the silos and acknowledge the hard truth and unrelenting reality, a reality in which we don't have the privilege of choosing one issue at a time. So it forces us to acknowledge the importance of concepts such as resilience, adaptability, absorptive and transformative capacity of health systems. So I would like that we have a lot of questions. We have a lot of questions. I think the easiest way to address this is to try at the very least to pose one question for each of where there have been specific questions about each presentation. Pose one question from the participants to each of the panelists. Hamza, Dr. Hamza, there has been a question about engaging the realities of having to engage people in planning when you're in an emergency situation. Can you talk briefly about whether this is a realistic thing? You know, everybody talks about community engagement. Is this possible?
So maybe in the early first response, it might be a little bit difficult to be like realistic about it, but like engaging the local people is very important. For example, I remember like till 2015, so after like 4 years of the conflict and serving, doing the health service, providing health service in the area, a lot of NGOs were still sending us like a specific package for treating patients. So like they have maternity package that is enough for 500 patients, and they send it. So they're not really addressing the specific needs and the difference between countries, between in like certain situation. I remember like we've never, for example, received a kit for cardiology, or a kit for any other like chronic disease, like diabetes, but they were like sending a lot of, let's say, amoxicillin, a lot of trauma kits that weren't really needed. Hospitals were like withdrawn with a lot of drugs and supplementals that weren't really like necessarily needed in that situation. So like basically engaging the local health services in kind of like yearly base or like term basis is very important to address like the changes in the situation on the ground, the changes and the specific for each country, like specific kind of like diseases and health system.
Thank you. Cole, I'll go to you next. There was a question that addresses specifically the contribution of migrants to health systems. Can you comment a little bit as part of that, so that they're not just consumers of the health, but they're actually part of and contributors of the health system as well?
Oh, absolutely. Thank you so much for that question. Look, I didn't have time to unpack the in-depth in the presentation, but look, there's no doubt whenever we talk about health systems, especially in resource limited settings, in conflict settings, the contribution of the displaced communities, refugee communities themselves in not only healthcare delivery, but also actively being trained and be part of that response strategy is absolutely crucial. I think any meaningful engagement of migration and health service delivery needs to be inclusive of the different migrant groups. And there's accountability for healthcare authorities, there's accountability for health systems researchers, there's accountability for funders in order to really engage with the various migrant categories. And I think this is an absolute tenet of health systems practice, policy formulation, and program formulation. So absolutely, thank you.
Okay, and Chris, you're next. A somewhat political question that relates to how you hold your own country and your own government accountable. If we really want to make an impact on climate change, how do you engage with your government, with the big P politics?
It's a good question, and reading the detail of the question, I want to point out that there are two main policy options for managing the health risks of a changing climate. One is reducing greenhouse gas emissions, and that is everyone's responsibility. There is, under the United Nations Framework Convention on Climate Change, a recognition of the additional responsibilities of major emitters that have put most of the greenhouse gases into the atmosphere. Because of the way the climate system works, there is a long period between emissions and when we have stabilization of concentrations in the atmosphere. And that period is several decades. And so if we only focus on reducing our greenhouse gas emissions, we're condemning everybody to suffer in the meantime. Look at the heat waves, the floods, the storms, the wildfires that affected so many thousands of people this year. We have to focus also on adaptation. We have to really strengthen our health systems. We have to be proactive in using environmental information to reduce vulnerability, to address the drivers of migration, to address the other issues that the panelists raised today. And we need to invest in those. A major challenge for particularly the strengthening of the health system is the very low investment. When you look at the international funds that are going to health adaptation, they're about 0.5% of all of the funds that have gone to adaptation. So there needs to be a real focus on these challenges and make sure that those investments come from the various development partners, from the research that is supposed to be conducted to help the low and middle income countries be prepared for what's happening over the next few months. And at the same time, really advocating for reducing our greenhouse gas emissions.
Great, thank you. And Valeska, can you comment as well on some of the major data gaps and how one integrates them in a useful way within the context of urban health as well as a big problem?
Thank you. Thanks, Pascal, for this question. Very good. Well, the way that we can integrate data, even if it is an incomplete data, as we are facing now with the COVID-19, we have to think about intersectoral planning and relationship. Because if we think about it, my colleagues presented, if we get out of the health sector, going beyond the health sector, not only for planning, but for data linkage, data organization, and consistency, we'll be able to understand better the question of in terms of actions, problem, understand the problem, and trying to draw actions. And actions should be done to local level. And doing that, we have to listen to our communities in a participatory process. I think this is very, very key question for local approach. And also we have to think about this political part, that we have to integrate the political, economic, social, and environmental efforts in terms to overcome governments like ours, unfortunately, that is very obscurantist, authoritarian, and denialist. So I think that we have to fight against this kind of approach. Thank you.
Great, thank you very much. Now, I think some of the thematic areas that draw all the presentations together have to deal with the power and the politics, which was the focus of the plenary that we had yesterday, for instance. There were, all of you addressed in some way the notions of resources as power, the impact of these issues that we've spoken about on populations and subpopulation groups, the issue of data and data systems for planning, and a little bit, I think, that Cole raised around the innovations in our methodological toolboxes. Again, I've been given my marching orders about timing, so I think it will be useful if I can go round, and if you have 3 key messages that you want people to, the participants to remember from this plenary, what would they be? And I'll start from you, Cole.
Thanks, Pascal. I'll try to keep to my 2 minutes. So I'm really addressing the health systems researchers out there. So I think what we need from looking at the landscape of migration health research is studies that look at how migrant groups navigate health systems in countries of destination and transit, more specifically by the migrant typology themselves. You know, for example, we need to look at labor migration versus, refugee categories. We know that, remarkably, we know more about refugees and forcibly displaced than we do of the low-skilled, low-wage migrant workers within regularized context. We know very little about the vast migration between south-south, south-north migration. 92% of our literature is from high-income countries. So, this is one of the challenges. Does labor migration really lead to development gains and poverty alleviation? There's a plethora of rich data on remittances, but have we explored the extent to which those translate to better health outcomes for migrants and their families? I think researchers also need to graph the tissue of migration cycle when undertaking health systems research. We need longitudinal studies, multi-country efforts, collaborations between North-South to really meaningfully answer some of these questions and to look at causality. People have mapped domestic legal policy frameworks in migration, but these are mainly within the EU and within high-income countries. There are really good tools out there, such as the MyPEX tool, for example, where we benchmark migrant inclusion within policies. These need to be adapted within LMIC context. And to what extent national health information systems have meaningfully integrated migration health or migration modules within their systems in order to generate the evidence to inform policy and practice. So I think these are just some of the quick reflective points for researchers. Over.
Great, thank you. Chris, I'll go to you next.
Well, thank you. I've got 3 key takeaway messages that I'd like people to use as they go forward. The first is we know climate change is affecting human health and well-being today. And the projections tell us that each additional unit of warming is going to increase the challenges that will be faced both in population health and by health systems themselves. The poor and the marginalized will be the most affected in all countries. And we, despite uncertainties, we have sufficient knowledge that health systems can start taking action now, and it's critical to do so. Thank you.
Thank you very much. Valeska.
Well, I think that I'm going back to the same that I mentioned before. I think quoting one article published in Journal of Urban Health some time ago, no data, no problem, no action. So I think that we have to really enhance metrics and innovative tools to motivate action for urban health. The other one is unequal society, unequal health. So global challenge mitigation and adaptation go hand in hand with efforts to achieve health equity through social determinants of health. And finally, we need to work in an intersectorial, community engaged, and given strength and emphasize the needs to be reinforced our health system. As like here in Brazil, we have the unified health system that still, although very damaged by some political decisions, it is working still as a very important entrance for primary health care.
Fantastic, thank you. And Hamza, last but not least.
So just like in conflict situations, really give your the priority for the real healthcare providers on the ground. It's kind of like a message to the NGOs, like remove your white man hat when you're dealing in conflict area, even though like you might have more knowledge than the people on the ground, but they are the people, like they are the real like healthcare providers, not the NGOs. The other thing, when you're stating about what's happening in conflict areas, like honor the victims by stating the truth, and not hide the truth by being neutral. So when people are displaced from a city, call it a displacement, not an evacuation. When hospitals are targeted, don't say the hospital was targeted, and state who targeted that hospital. I will quote just a writer by saying, like, if you are neutral in situation of injustice, you have chosen to take side of the oppressor. So just always remember that.
Great, thank you very much. I'd like to thank the panelists again for their time, for sharing their expertise and their preparedness to forego sleep. Chris, thank you, to be with us today. If I may, I'd like to draw out some of the key points of the plenary. The COVID-19 pandemic has been devastating, but the silver lining to this dark cloud is that change is possible and it can happen fast. The direction of change is not always desirable, but we have an opportunity to observe and to learn. Like the COVID-19 response, the issues addressed in this plenary are outside of what we think of traditionally as the health sector, but they undoubtedly have an impact on the health system, and we have to engage proactively and not just reactively. Developing and understanding skills and strategies to deal with the politics were addressed by the brilliant panel from yesterday's plenary, so I won't repeat those points. Similarly, the issue of funding, specifically equitable funding, has been explored to some extent over the last 2 days. This has been about how to ensure that power relations in donor-recipient relationships are equalized sufficiently to enable empowerment and ensure local relevance of evidence generation. And I have to commend the very positive messages that I've heard over the last 2 days from the funders who participated in the discussions. But financing for these issues is absolutely critical and underpins the politics of this area. And so we do need to look at the other side of funding, which is the sources of funding. And it used to be in health that we talked a lot about the percentage of contribution from governments and so on to go into these issues. It's interesting that financing for all 4 of these areas that we've spoken about today actually relate to supporting global public goods. These are not issues that relate to individual nation states, and there is no doubt that in real terms, the size of the overseas aid pie is likely to shrink to deal with a post-pandemic economic recovery. So our collective responsibility is to also engage with alternative sources of funding. And another, again, an issue that Fadi had raised yesterday, mentioning the private sector. And another possibility is looking at new models focusing on global public investments. The third point I want to draw out is that of data. The potential of combined data sources to providing the evidence for planning is enormous and has barely been tapped. Combining data sources that link megacity plans, for instance, to meteorological data, to hospital planning, to mobile populations is technically possible. We all have bank accounts, for instance, that we can access, whether we're in London or in Nigeria. And of course, there are caveats to data privacy, but these are not insurmountable problems. There are these present opportunities to innovate, and most of the obstacles relate to developing the governance and regulatory frameworks, building the capacity across all the areas of compilation, analysis, and reporting, and a willingness to share data, which, like many other things, is becoming a new currency and an opportunity to exert power and authority. My final point related to the above is the diversification of our methodological arsenal. The tendency to fall back on traditional models of research and only privileging particular types of evidence forces us to perceive everything as a nail because all we have or all we want to use is a hammer. We need to rediscover the intellectual curiosity of childhood and to be open to new ways of knowing, perhaps new to us, but well used by other disciplines or other cultures and communities that give us a deeper understanding about how to conceptualize and deal with these complex issues as a whole, rather than as deconstructed parts. Systems thinking from complexity science, for instance, has taken a good decade or more to gain real traction in health systems research since the early publications by de Savigny and colleagues. And I can tell you from personal experience that working through feedback loops in participatory sessions with colleagues across various sectors is a great icebreaker and a diplomacy tool and can be a huge amount of fun. So as they say, watch this space, and thank you again very, very much to the panel. I want to end this session by stressing again that following the launch of Future Scenarios for Better Health and Social Justice at the end of the first plenary yesterday, I'm pleased to invite all participants again and HSG members to respond to the initiative's second crowdsourcing survey. Once again, we're seeking your insights and perspectives on the issues and themes that we have just explored together during this plenary. Straight after this plenary ends, we'll be sharing the link to the second crowdsourcer focusing on the plenary. So I hope the discussion will inform your answers to the crowdsourcing survey. All 3 crowdsourcing surveys will close on Monday, the 30th of November. So please them and contribute. Your insights are vital to this process, and we hope you'll want to be a part of it. Thank you. Enjoy the rest of the symposium, and I really hope you enjoyed this session. Please tell us if you didn't, so we can do better next time. Thank you very much, and have a good evening.